first video of this two-part series, we discussed how to interpret study results. We introduced two key pieces of information to look for: the point estimate, or effect size, and confidence intervals. Recall that the point estimate tells us about the size and direction of the effect. The size of the effect refers to how much change occurred, or how big or small the difference is between groups. The direction of the effect refers to whether patients improved or worsened, or which group did better. In this video, we will discuss confidence intervals. Confidence intervals help us to determine our level of certainty. Essentially, how confident are we that the same result would occur if we were to repeat the study again? Or more importantly, would this be the result if we were to provide the intervention to a patient in the real world? Level of certainty is commonly informed by two statistical measures: confidence intervals and p-values. The most valuable measure we can use to assess level of certainty is the confidence interval. A confidence interval provides a range of values within which the true point estimate is likely to fall. Let's say we are conducting a study and our selected outcome is a 100 millimeter VAS. Our point estimate indicates a between-group difference of 30 millimeters. A 95% confidence interval ranging from 10 to 50 would tell us that if we were to repeat the same experiment over and over, 95% of the time, the result of our study would be an effect estimate somewhere between 10 and 50 millimeters. Confidence intervals are often expressed within brackets following the point estimate, like this. The width of the confidence interval tells us how precise our point estimate is. A narrower confidence interval indicates a more precise estimate with less uncertainty, while a wider interval suggests less precision and greater uncertainty. To illustrate, compare a point estimate of 30 millimeters on a 100 millimeter visual analog scale with a 95% confidence interval ranging from 25 to 35 millimeters, to the same point estimate with a 95% confidence interval ranging from 10 to 50 millimeters. The confidence interval in the top example is narrower. Therefore, our point estimate is more precise, and our overall level of certainty is higher. P-values measure statistical significance and tell us how likely it is that our results are due to the real effect of an intervention being tested instead of due to chance alone. P-values range from 0 to 1 and actually represent the probability of obtaining a given point estimate in the event that the intervention being studied has no real effect. Going back to our example of a point estimate of 30 millimeters on a 100 millimeter VAS. Just by looking at the point estimate, we may think there is a real and clinically important difference between groups. A p-value of 0.5 means that there is a 50% chance that our point estimate is actually due to chance, and that there is no real difference between the treatments being compared. Compare this with a p-value of 0.05, or a 5% chance that our point estimate is actually due to chance alone. We are much more confident with the lower p-value. It is important to remember that p-values are dependent on sample size. If a sample size is too small, you may never achieve statistical significance, even if the point estimate indicates a very large effect. The reverse is also true. If you have a very big sample size, even a small and clinically unimportant effect can be statistically significant. Thus, p-values on their own can be misleading, and we should never base our judgments on p-values only. While p-values provide a measure of probability that a real effect exists, it does not provide information about the magnitude or clinical importance of that effect. In addition to statistical significance, the confidence interval gives us this information by providing a range of values in which the true effect estimate is likely to fall. To illustrate confidence intervals and p-values, let's revisit our example. Recall that in this study, researchers randomized participants with sciatica to receive either acupuncture or sham acupuncture for 4 weeks. Their primary outcome was leg pain, measured using a 100 millimeter visual analog scale immediately following the intervention and at 16 and 28 weeks. In Table 2, 95% confidence intervals are provided with the between-group effect estimates in column 4. Immediately following the intervention, the point estimate is a 7-point difference in change in leg pain, favoring the acupuncture group. The confidence interval range is between 14 millimeters and 1 millimeter greater improvement in the acupuncture group. This means that if you continue to repeat this experiment 95% of the time, the effect of acupuncture is that it lowers leg pain anywhere from 1 millimeter to 14 millimeters more than sham acupuncture. Note that this range suggests the real benefit of acupuncture immediately following treatment is likely to be very small and not clinically important when compared to sham. Notice that the confidence interval excludes 0. For a continuous outcome like the VAS, the line of no effect, or the point where there is no difference between the two interventions, sits at 0. In this case, the entire range of values falls just to the left of this line. Therefore, this finding is considered statistically significant. Let's move over to the final column of this table, where the authors provide p-values. For this point estimate, we see a p-value of 0.029. This means that there is a 2.9% chance that a difference between change scores as large as 7 points will occur by chance alone if there really is no difference between acupuncture and sham. This is further confirmation of a statistically significant finding. If we just focused on the p-value, we might conclude that this treatment provides benefit, but we would not know how clinically meaningful the benefit is likely to be, or whether acupuncture has the potential to do harm. The confidence interval tells us that the benefit of acupuncture is likely to be very small at most. However, it is not likely to cause harm, as the interval falls to the left of the line of no effect. At 16 weeks, the point estimate is a 4 millimeter difference in change in leg pain favoring acupuncture over sham. The confidence interval range is between 19 millimeters lower and 11 millimeters higher in the acupuncture group. We are 95% confident that the effect of acupuncture is that it lowers leg pain by as much as 19 millimeters or increases leg pain by 11 millimeters. This means that acupuncture may be better or worse than sham acupuncture. Obviously, we are not very confident in the effect estimate at 16 weeks. Note that this interval includes 0, crossing the line of no effect. In this case, the range includes both positive and negative numbers, both improvement and worsening of symptoms. This is not a statistically significant finding. Moving over one column, we see a p-value of 0.583 at the 16-week follow-up. This means that there is a 58% chance that a difference in change scores of at least 4 points will occur if there is really no difference between acupuncture and sham. This is further confirmation that our point estimate is not statistically significant. Recall here that the corresponding confidence interval crossed the line of no effect. When this happens, the p-value will also be high, indicating a high probability that the effect estimate reflects no real difference between two groups. To conclude our discussion, let's review some of the advantages that confidence intervals provide with respect to making decisions about certainty in an effect estimate. Confidence intervals provide us with additional information that is not provided with other estimates of statistical significance, such as p-values. First, confidence intervals provide us with a range of possible values within which we are 95% confident that the true effect estimate is likely to fall. This range gives us a better understanding of the potential magnitude of the true effect. By examining the upper and lower bounds of the interval, clinicians can determine the smallest and largest possible effect sizes that are likely to occur. Second, the width of the confidence interval reflects the precision of the effect estimate. In other words, how much uncertainty there is in the outcome. A narrower confidence interval surrounding the point estimate provides greater precision to the estimate and less variability. This information is valuable as it helps clinicians evaluate how much variability there may be in the outcome when the intervention is provided to patients. Third, by comparing the range of values included in the confidence interval in relation to the line of no effect, we can weigh the potential for benefit versus harm. The range of values can also be compared to some threshold that we might consider to be clinically important. Using this information, we can determine whether the intervention is likely to be associated with clinically important benefit or harm. Finally, confidence intervals provide us with the more nuanced understanding of statistical significance. Even if an effect is not statistically significant based on the p-value provided, or based on a confidence interval range that crosses the line of no effect, if the confidence interval includes our clinically important threshold, it suggests the possibility that the real effect may still be clinically important. In summary, when interpreting an effect estimate from a clinical study, it is important to contextualize the finding with a measure of certainty or precision. Ideally, this information should come from confidence intervals. Confidence intervals can play an important role in informing clinical decision-making. The interval provides a measure of certainty around the point estimate, helping clinicians to evaluate the likely magnitude of benefit or harm and the expected variability of the outcome if they were to implement an intervention in the real world. This ultimately leads to a better interpretation of findings and more informed clinical decision-making, the ultimate goal of which is to improve patient outcomes.